Welcome to GP Trainee Teaching Lockdown Learning Session 5. Today we're going to cover GP emergencies, men's health and portfolio GP careers. And I'm also going to touch on the update from the Royal College about the exams for AKT and CSA happening in July, or the replacement for CSA rather. Okay, so let's get straight into it. Just for those coming for the first time, very brief introduction. My name is Dr. Mohibur Rahman. I'm a portfolio GP. I'm going to talk to you about what that means and my portfolio career in the last third of this session. And I'm the medical director of eMedica. Okay, so I've got different roles, which I'm going to talk to you about later. In terms of the format, we're going to cover 3 topics, 2 clinical, 1 careers related topic. It's very interactive, so please do get involved when we do the questions, when we do the cases. There'll be rapid reviews of current guidelines related to the topics that we cover and time for discussion. So that's what we're going to do. And just a quick update to the exam. So the cancelled April AKT is going to be held in July. The date is to be confirmed, but personally, I think it's likely to happen in the first half of July, because the whole idea of putting it on in July is that we want to reduce the number of doctors that need an extension, so that those people that plan to CCT in August and maybe have got jobs lined up that they want to start shortly after August, that there won't be a delay. For that to happen, realistically, the exam has to happen in the first half of July to allow a couple of weeks for it to be marked and for ARCP to happen. If they hold it at the end of July, it's going to be difficult to turn that around in time. Okay, but hopefully we'll get an update on the date of the exam soon. And then the cancelled March, April, May CSA has been cancelled, i.e. they're not going to rehold that anytime soon. Instead, a temporary assessment is going to be developed based around recordings of audio and video consultations or videos of live consultations if you're still seeing some patients face to face, that you will then submit to the RCGP examiners and they will mark them remotely. Now, I did the old MRCGP, and actually I'm part of the transition cohort. So I actually did video recordings. We didn't used to do audio, but I had to record videos on a VHS cassette. I had to pick my 7 best ones from months of videoing, okay, and then submit it. I did both summative assessment and MRCGP, and then I piloted the new CSA and actually sat the CSA in the very first sitting of the new CSA. So I've actually done both assessments. And what they've said is they're going to base this new assessment on the old MRCGP video assessment, but marking will be mapped to the new CSA domains because there are some differences in the old mark scheme and the new. Full details of that are awaited, but hopefully won't be too long because people need to know what's going to be assessed so that they can start preparing for it. What I would encourage you to do, those of you that are due to CCT in August and going to do the CSA replacement, is make a start now on getting used to seeing yourself on video. Record some consultations, watch them back with your trainer or watch them back yourself just to see, oh, actually, I could have explained that more clearly, or actually, I look distracted there. I'm not making good eye contact. It looks like I'm not that interested. And then also remember that they're still going to be testing. If you're seeing real patients, can you take a good history? So the data gathering is still going to be the same domains that they're testing. They're still going to test when you do your management, is it up to date and based on current guidelines? So you still need that knowledge base. And then the third domain they test is interpersonal skills. So they're still going to be assessing, are you communicating clearly? Are you person-centered in your approach? Are you involving the patient where it's appropriate in shared management and things like that? Okay. The key message I want to say to all of you is if you're planning to sit either AKT or CSA or both in July, just keep revising, keep practicing, and I'm glad that you've joined us today. Okay. And those of you that are planning to sit it the next cohort, AKT, the next AKT is October. It's likely to go back to completely normal. And they may restart CSA by October, November. That you still, again, need to make sure you're consolidating your knowledge, still seeing patients, still practicing, still get feedback on your communication. Okay, so that's all I wanted to say about those things. So let's go back up to our main program today. We're going to cover GP emergencies first, then we're going to look at a men's health interactive case, and then I'm going to talk to you about portfolio GP careers in general and my portfolio careers specifically, and then there'll be time for questions and answers at the end. Okay. So if we start with GP emergencies, we're going to look at these 3 areas. So if we start with anaphylaxis, we're going to go straight into a question, and when we do, I'll launch a poll after a little bit of time. So I'll let you have a look at the question first, and then I'll launch a poll shortly. Okay, that's time. I'll close that now. Okay, so I can see that the most popular answers were C, okay, 1 in 1,000, 0.3 mils. That was the absolute most popular answer, okay. IM adrenaline 1 in 1,000, 0.3 mils, the most popular answer. And then after that, actually fairly even between A, B, D, E. Very few people picked F or G. No one picked H, okay. So the first thing is that 1 in 10,000, this is what we use when we're treating, in an ALS situation, when you're treating someone in cardiac arrest, and you give that IV. Okay, so IM, it's always a standardized dose. It's always 1 in 1,000 concentration. So this is one of the bits of technique that sometimes you can eliminate. So you can eliminate E, F, G, H. Okay, we'll get rid of all of those. So we're really picking now between A, B, C, D. And then the key thing here is the age. Okay, this girl is 3. And then what's happening? This is what we call a two-step question. The answer is the management, which is the second step. The first step is working out the diagnosis. Now, they have not said the diagnosis is this, but in a two-step question, they will always make the diagnosis part very, very clear. They're not trying to trick you. It's not an atypical presentation. You can all see that this is anaphylaxis, right? Okay, so anaphylaxis in a 3-year-old, that's what we're looking for. So the correct answer is D, 1 in 1,000, 0.15 mils. So actually, only 14% of you got that right, okay, of those that used the poll. As I said, the most popular answer was this one, 0.3 mils. The key thing is the age here. Another bit of technique. Some of you picked 0.5 mils, actually about 10% of you. 0.5 mils is the adult dose. And so sometimes that happens because people saw that the patient is 30, but the patient isn't the one, the patient you're seeing isn't the one that's having anaphylaxis. It's her daughter who happened to have had the appointment before with the nurse and has had the jab, who's only 3. And so a bit of technique, sometimes if you don't read the question carefully, you could have the knowledge and still get the question wrong because you're trying to treat a 30-year-old rather than a 3-year-old, okay? So anaphylaxis, we always use IM adrenaline in the GP setting. Why? Because the additional time that it's going to take you to put a line in to give it IV, because you can give adrenaline IV in anaphylaxis. Like in the hospital setting, if someone already had an IV in, you could give IV, it's slightly quicker. But in GP, we're always going to use IM. Remember, the AKT is a GP exam. And so IM, because what's going to kill you in anaphylaxis is your airway closing up. And so you want to get the adrenaline in as quick as possible. You don't want to be messing around, especially in a 3-year-old. Think that it might not be easy to get a line in, okay? So that's fairly standard. That is IM, and it's always 1 in 1,000 concentration. They come in pre-filled syringes. So a child 12 and above and adults is the same dose. It's standardized at 500 micrograms, which at 1 in 1,000 is 0.5 mils. 6 to 12 is 300 micrograms, 0.3 mils, which a lot of you picked. That was the most popular answer. And then under 6, which this child was 3, is 150 micrograms, which is 0.15 mils. And then in GP, we're going to arrange an admission because they're going to need to go into hospital, get IV hydrocortisone, IV antihistamines and things like that, and make sure that they've not had any significant damage and be monitored for a few hours before they're going to be sent back. Okay. And I just remove that. Okay, good. We're going to move on to another question now. In the exam, this is what's called a drag and drop question. So in the exam, you'd actually be picking which bits you want and dragging them to the right section. So just write down on a piece of paper which order you do this, i.e. what would you put number 1, number 2, number 3, okay? Again, I'll give you 50 odd seconds to do that. Okay, that's time. Don't worry if you've not written it in the chat, as long as you've got in your mind what you do. I'm going to show you what you do. So in the exam, this is what you do. You'd actually drag, okay, the key thing here is that this patient is 79, so she's an adult. So this is adult basic life support, right? 999 is being called, ambulance on the way, okay? First thing we're going to do is give them 30 chest compressions. After that, we're going to give them 2 rescue breaths. After that, we'll do CPR at a ratio of 30 to 2, okay? So you'd need to have all 3 of those in the right sequence to get the 1 mark. Even if you had 1 in the wrong place, you just get no marks, right? And the reason that the 30 chest compressions comes first is that this is an adult. Most adults will have a cardiac arrest, okay? And so the compressions are more important before the breaths. Whereas if I show you the algorithm for pediatric BLS, you've shouted for help, open the airway. If they're not breathing, most children, if they arrest, they have respiratory arrest. So the first step is 5 rescue breaths. And then after that is 15 chest compressions. And then the ratio for CPR is 15 to 2 in children, okay? Whereas in adults, as we've just done, is 30 chest compressions first, then 2 rescue breaths, and the ratio is 30 to 2, okay? Now, in the current circumstance, with COVID, in a lot of cases, because we don't want to expose yourself to risk, you might be doing just compression only based CPR, okay? But bear in mind, this exam was written in April, all right? If you were to get questions on this, it would be under the normal guidelines, all right? So let's look at child health. Time. Okay, so interesting. The most popular answer, nearly half of you can probably see the poll breakdown, but 45% picked A, call an ambulance and give 600 milligrams of IM benzyl penicillin. The next most popular answer was also to give IM benzyl penicillin, but at a higher dose, 1200 milligrams, okay? After that, it was giving erythromycin orally and arrange an admission, or call an ambulance, but don't give antibiotics until they arrive. So if we look at the question, key things that are really important. That it's a 10-year-old boy. Age is really important because dose is based on age, okay? They've got a 4-day history of malaise, lethargy, fever in the last 24 hours. And then look at this, non-blanching purpuric rash on the trunk and a temperature of 38.6. So again, feel free to type in the chat, which I'll reopen, what you think the diagnosis is, because again, this is a 2-step question, okay? The first step is working out the diagnosis here, right, okay? And you notice that he's had an allergic reaction to penicillin, but this is very important, with a rash when they had it before, not anaphylaxis when they had it before, okay? So this fits with meningitis, doesn't it, all right? Non-blanching rash, temperature, and the symptoms, that's what we'd be thinking about. And so, you can all see that this is an emergency, right? Okay, so let's look at the right answer. The right answer is B. And that's because of the age, all right? And so most of you, unfortunately, would have got that one wrong because I said the most popular answer was 600 milligrams, okay? That's just too low a dose because they're 10, okay? So if we go through the thresholds, anyone with suspected meningitis needs to be in hospital because in GP, we're not going to be able to do a spinal tap. We need to get urgent bloods. They need to be managed and they need to be monitored. But before they go in, it's important that if we can give that first dose of benzyl penicillin, we can significantly improve the survival rate. We can significantly improve the likelihood that they, do better, have better outcomes. So what we shouldn't do is we shouldn't delay the transfer, but equally, while you're waiting for the ambulance, you shouldn't delay giving the dose, all right? Now, again, if you're in hospital and you had someone you thought this was meningitis, we could give it IV. It works slightly quicker. If IV is not possible, then IM is, fine. Like in GP, often we won't have access, especially in a child, we're not going to be able to get an IV in. And so we can just give IM. It's fine, okay? And then the age determines the dose. So under 1, so a baby, 300 milligrams, 1 to 9, 600 milligrams. Now this child was 10 and above is 1200 milligrams, okay, which is the same as the adult dose. And so one of the things that you'll see, this happens in the exam, that they'll often test knowledge where it's right at the threshold. Like if I'd have said 15, you'd all pick the same as the adult dose, 1200. Everyone would get it right, okay? But knowing that 10 is where it changes to that dose, you see, that's one of the thresholds. They'll often test that. And then after picking benzoyl penicillin and the dose, the next most popular answer was not giving it. And so here again, what does the guideline say? That you should only withhold benzoyl penicillin if they've had a clear history of anaphylaxis. A history of a rash is not enough to withhold it. It's not a contraindication. Why? Because if you withhold it because of a rash, they might end up dead. They might, that delay might mean they go into multi-organ failure, full-blown sepsis, and die, right? And so if they've had anaphylaxis, the risk-benefit equation is that actually, if they have anaphylaxis, that's going to probably do more harm than good with withhold, okay? But if it's just that they've had a rash or a sensitivity rather than a documented anaphylaxis, do not withhold meningitis. That's what the NICE guidelines say, okay? So that's important. So someone's asked, what if they had a clear history of anaphylaxis? So if they had a clear history of anaphylaxis, then you're going to put out a call for the most urgent ambulance, okay? In which case they're going to get into hospital typically within 15 minutes because then they might be able to give, for example, IV something else that's not going to interact. By and large, we're not going to have, we all have, as GPs in our emergency drugs box, we have IM benzoyl penicillin for this purpose. What we're not going to have is, IV antibiotics that are not penicillin based. You're not going to have those to hand in GP. In hospital, they can give things like cefotaxime. They could give things like, other things that they can give that aren't going to be safe in someone who's got a penicillin allergy. Okay. And then, so I've covered 3 different GP emergencies there. The reason I wanted to cover this and highlight this is that a lot of doctors don't read up on emergency care in general practice. And the examiners have highlighted that this is an area, both in AKT and CSA, that doctors often struggle with, okay? They often give more importance to the routine care, chronic disease management. And of course, that's a huge part of GP, but the curriculum doesn't just cover what we do in hours. It also covers everything that we do out of hours, but also emergencies that we might see. Like, you could have a patient suddenly collapse, all right? And you might need to do CPR in the waiting room. You could have a patient who suddenly loses consciousness, and then when they come to, you've got to assess their GCS and see if they need to go in. Could it be a head injury? You could have someone have an acute severe asthma attack, in the nurse's room. You could have someone presenting with slurred speech and weakness, and they're actually at the first parts of an acute stroke. I need to admit them. Or they come in, they just think it's a musculoskeletal chest pain, but you think it's an acute coronary syndrome, and you need to admit them. Cauda equina, someone with back pain, and they just think it's to do with lifting at work, but they've got bowel and bladder symptoms, and you think that it's a cauda equina, you need to admit them. Someone worried about a sprained knee, but it's actually they've got a fever and it could be septic arthritis. Sudden onset loss of vision, could it be a central retinal artery occlusion? Could it be acute closed angle glaucoma and they need to go into hospital? Seizures, especially if you think someone might be going, at risk of, like, first seizure needs to be assessed, status, febrile convulsions, first one, that needs to be seen in hospital. New diagnosis of diabetes in a child, usually it's type 1, they need to be seen, or in someone in any age, if you think they've got diabetic ketoacidosis, again, that needs to go into hospital, doesn't it? Okay. Acute abdomens, appendicitis, pancreatitis, testicular torsion, sepsis. These are just some of the things that have featured in the exam in the past that people often struggle with. So it's important that you cover, common emergencies that we might need to deal with as a GP. Anything where you might need to admit someone into hospital from GP, can you see that would class as a GP emergency, right? Okay. Now, just wanted to mention that for those of you that are planning to sit the exam in July, and maybe for those that are planning ahead, I mentioned this last week, but we've updated fully our online versions of our AKT course, which has got 8 modules and a full AKT mock. You can subscribe anywhere from a month to 12 months. Our high-yield clinical cram-up, we've got updated recordings, but we'll also be running a live version at some point at the end of June. We're just waiting to confirm the dates. We'll do that by next week, okay? Our Stats Made Simple webinar, again, the recording's available. It's updated in April, so it's bang up to date, but we'll be running it live at the end of June. Our organizational domain webinar, so cover all the key admin topics in 3 hours. That's all the key stats topics in 3 hours. That's all the high yield clinical topics that examiners mentioned in their reports. These things come up again and again from the last 10 years worth of reports in 3¼ hours. And then we've actually just launched all of this and more in our AKT Pass Plus online package. So we already had this package for live dates of courses, but we've got it as an online package. So it's 4 webinars, 2 full-day course recordings, online revision questions, 2 full AKT mocks. So there's over 100 hours of learning. So you've got a 2-hour recording of the AKT Masterclass webinar, good starting point, orientation to the exam, exam technique, and a teaching mini-mock. We've got our AKT online course, 7 hours of learning, stats webinar, 3 hours, admin webinar, 3 hours, clinical webinar, 3¼ hours, AKT 200 question mock crammer, full day course recording, 8 hours, 1,700 plus online revision questions. So between these questions, the mocks and the questions in the crammers and the course, there's 2,300 plus questions, and then 2 full AKT mocks between all of this. So just over 100 hours of learning. Again, you can subscribe anywhere from a month to 12 months. And I mentioned the case cards to you last week, so up to date. They're published just last month, or March 2020 actually. So but bang up to date, 2020 guidelines. All of these, the online, the case cards, everything. Remember, you've got a 20% discount on with that code lockdown. I warned you last week that code expires midnight tonight. Okay, so it's all lowercase. Use that lockdown. You can just go to our homepage, emedica.co.uk. I'll just show you. And then if you're looking for AKT, just pick. So the Pass Plus online bundle, for example, is here. You just click it. You can go anywhere from 1 month to 12 months. Put the code in, it will give you a 20% discount. Okay. If you go back to the homepage, we've got, if you just wanted the AKT course on its own, the 200 question crammer recording, or any of the webinars, they're all available there. And for CSA, we've got our 100 case crammer, we've got cases to practice. Okay, so we've got all of that available. I'll show you a bit more about that later. Okay, so remember that expires midnight tonight. So back to the next teaching slot, which we're going to cover men's health. Okay, and I'm going to do an interactive case. So again, I'll show you the kind of information that you have for CSA, for those of you that are coming early, but also for those of you that are going to be recording consultations. Imagine this is an appointment via video, okay? Or you could imagine that you had them in the room and you're going to video it. Similarly, you wouldn't have an iPad, but on your eMIS or on your Vision or your System 1 computer system, you'd have a summary. So have a quick look at the summary, and then we'll do an interactive case. Okay, so not much information to see, all right? 51-year-old gentleman, past history of asthma. The fact that they're only on salbutamol inhaler PRN suggests that the disease isn't, really, really high risk, if you like. They're not someone needing steroids. They're at the base level of treatment, okay? That doesn't mean that it's not worsened, does it? Okay, so let's make a start. I'll open up the chat. The chat is open. Okay, so feel free, if you'd like to kick us off. I'll imagine someone has said, hello, introduce yourself, okay? Actually, you know what? Let's do this. If we're doing a video, there are some things that you're going to do slightly differently compared to when you've got the patient who's walked into the door. So let's have someone make a start, okay? Just type into the chat the first thing you'd like to ask me. So someone's gone straight with, how can I help you today? You see, if you're doing a telephone consult or a video consult, it'd be good for you to make sure you've got the right person, because someone else might be in the room or someone else might be actually setting it up for them. Imagine you've got an elderly patient, their son or daughter might be setting it up for them, and it actually might not be them. So if you just make a start, you might actually be consulting with the wrong person. So it's good to just check. So start with, hi, my name is Dr. Rahman. I'm one of the GPs at the practice. Just before we begin the consultation, I just need to make sure I'm speaking to the right person. So can I just confirm your name, please? Don't say to them, are you Harold Kumar? Because someone who isn't could say yes, all right? Just say to them, okay, could you confirm your name? Okay, so, okay, I'm Harold Kumar. And then could you confirm your date of birth? 21st of January, 1960, whatever would make me 51, you'd have the date of birth, right? And let's just confirm your address, okay? There we are, we've got that done. Okay, and then now we could get into it. So someone said, okay, how can I help today? Doc, I want to have that test for prostate cancer. I read about it in this Men's Health magazine, and I want to get that test. Can I have a test? Okay, so that's their opening line. They've asked for a test straight away. So let's carry on from there. What would you like to ask next? Who's got a question for me? So we've done the introductions, we've made sure we've got the right person, we've asked them the open question, and they've said, that they want this test. So someone's asked, why do you want that test? Well, I read about this test that sometimes you could have the cancer and you might feel well, but you've still got it. Now, if I've got cancer and there is a test, I would much rather know about it so that it can be treated early. I don't want to be walking around with a cancer. I got kids to think about, So that's why I was reading that you can get tested. So I thought, I'll have a test. So someone said, what do you know about the test? Well, I read that it can be used to pick up prostate cancer early, and that, yes, sometimes, it's not fully accurate. It's not a perfect test, but that the main thing for me is that what that worried me is that you could feel fine and you could have cancer. And so if there's a test for it, I want to get it done. So that's really the main thing I know about it. And also that I know it's a blood test. And I've had blood tests before, so that doesn't worry me. So someone said, why do you think you might have got cancer? Well, I don't know if I've got cancer. That's the whole point. What I was reading in this article that worried me is that it said that you could feel perfectly fine and you might still have cancer, okay? That this type of cancer, prostate cancer, more common as men get older, and I'm in my 50s now, I'm not a spring chicken anymore, that they can actually feel fine and still have it. That's what worries me, okay? So someone's asked, do you have any issues with your prostate? How would I know if I had issues with my prostate, doc? I don't really know much about that. So someone's asked that, how are you feeling otherwise? Yeah, I feel all right, doc. My asthma's fairly well controlled. I do sports now. When I was young, it was quite bad. I used to have like 2 different inhalers when I was in school, and I sort of grew out of it, I guess. At school, I couldn't really play a lot of sports. I was quite chubby then, but now I'm really into my fitness, and that's why I was reading that Men's Health magazine. So I do my weights, I go running most days, so I feel good. Someone's asked, any problems with my urine? What do you mean by problems with my urine? Like, I pee, that's normal. I've not noticed anything different. Someone's asked, any problems with your waterworks? No, not really. I as I'm getting older, I do sometimes go once in the night. Apart from that, no change, no difficulty passing it, none at all. Okay. So someone's asked about any weight loss. Yeah, actually, I have lost a lot of weight, doc. I'm quite happy about that. Someone's asked, any loss of appetite? No, my appetite's fine. I eat healthy. I watch what I eat, and I make sure that I have a lot of protein because I'm training. I try to cut down on carbs. That's helped me a lot to lose my weight. But I've got a good appetite. I'm just careful about what I put in. Okay. Someone's asked, any blood in my urine? Heavens no, doc. If I had something like that, I would have come much sooner. Any dribbling? No dribbling. Someone's asked, any family history of cancer? Yeah, actually, there is. So my father had lung cancer, and he actually died of lung cancer. But that's one of the reasons I've never smoked a cigarette in my life, is I've seen from a young age how it affected him. And I saw, how he struggled in the later years. Before he had cancer, he had that COPD thing. He was like always coughing, so he struggled with it for years. So I seen that. So that's another thing. There's cancer in my family. Do you see? Someone's asked, is your weight loss intentional? Yeah, I've been trying. As I said, I go to the gym, I watch what I eat. I'm on a low carb, high protein diet. So yeah, I'm very happy about the weight I've lost. Someone's asked, any discharge from down below? No discharge, nothing like that. Someone's asked, any erection problems? Hang about, doc. That's a bit private. You suddenly to ask about that. All I want to know is, can I have this test? We asking all these questions for? Can I just, it's a simple blood test, right? Can you just book me in for the blood test, and then I can see with the results, and then if I'm all clear, that's all good. if I've got it, I'd rather know so you can treat me. Now, we'll come back to this later when we talk about interpersonal. But you see, while that's a very important question, if you suddenly ask something like that without signposting why you're asking it, some patients will get offended, or they'll be embarrassed, or they might just not follow why you're asking it, because they might not know that a problem in the prostate can be manifested by a problem with erection. So something like that, it's really important to signpost. So we'll talk about the technique of signposting later, okay? So someone's asked about back pain. No, I mean, sometimes if I'm doing kettlebell swings, when I'm doing my circuits, if I do a heavy weight, it sometimes hurts a bit for the day or two after. But I know that's because of that, because when I'm not doing those exercises, it doesn't hurt. I don't generally have a problem with my back. Okay, someone's asked a really good question. How much weight did you lose? Okay, I lost a 1.5 stone over the last 6 months. Yeah, since I got a personal trainer, and then I go to the gym 3 times a week. I've made changes to my diet, a lot less carbs now, a lot more protein. Okay, so I'm very pleased with that. Okay, someone's asked, do I smoke? No, doc. As I said, I seen my dad and what it did to him. I've never smoked a cigarette in my life. I never would touch it. Filthy habit. Okay. Okay, so someone's said something really nice. They've said, I hear you. You've read about the test and you'd like to have a test to make sure you don't have cancer and you don't have any problems with your water. Is that right? Absolutely, doc. I feel fine in myself, but I've just read that, you can feel fine and still have it. And if there is a test for it, I'd like to be tested. So can we go ahead and organize that? Okay. Right, great. So I'm going to pause it there. I think, we've asked some really, really good questions. All right. Let's move on and look at what are the key things in the data gathering, okay, that might be missing. And some of you might be thinking about some of these now. So in terms of symptoms, remember that a lot of patients with early and even some patients with late prostate cancer, quite advanced disease, may be totally asymptomatic. Okay. So having no symptoms isn't in and of itself clear that someone can't have it. All right. That's something important to know. The symptoms that they may have, they may be related to the prostate being enlarged, and it could be just benign prostate disease, or it could be prostate cancer. So the typical things that you want to ask about are lower urinary tract symptoms. Okay. Again, in the exam and in real life, it's no good saying, have you got any lower urinary tract symptoms? A patient's not going to understand what you mean. You've got to be specific, right? So things like, do you find that you're peeing more often than usual? Again, don't say, have you had urinary frequency? That's going to get you marked down in the interpersonal domain, right? For using technical words or jargon that most patients wouldn't understand. Do you find that you feel desperate, like when you need to go, you can't really hold it, you have to go straight away? Do you find when you get there that you feel like you can't get started? Do you find that towards the end, it's like it dribbles on and on and on, terminal dribbling, okay? Overactive bladder, so that irritation type symptoms. Loss of appetite, someone had asked about that. Having weight loss, really important to get the detail. Do you see, I'm really glad someone asked, were you trying to lose weight? How much did you lose? What have you done? Over what time? Because if someone says, oh, I've lost some weight and I'm really happy, and you don't ask any more detail, you might think, oh, that's not unintentional because they're trying to lose weight. But what if I joined the gym a month ago? I've only been once for induction, never been since. And in that month, I've lost 2 stone. I'd be really worried. That could be a cancer-related weight loss, a red flag weight loss, rather than this gentleman made changes to his diet, exercising 3 times a week, and then got a personal trainer and has lost, 1.5 stone in 6 months. That just sounds like he's done a really good job with his exercise and his diet. I'm not worried about that. Do you see? Okay. Hematuria. So have you noticed any blood? Someone asked about that. Erectile dysfunction. It's a very important question to ask, so I'm glad that you've asked it. But in terms of how we ask it, we need to be careful, right? I'm going to come back to that in the interpersonal. Lethargy. Fatigue is a general, sign that someone might have a malignancy or might have become anemic secondary to a malignancy. And then often, before someone gets any actual prostate symptoms, they actually get symptoms of the metastases. So a really important question to ask about, and someone asked about new onset low back pain, but also any achy type pains or deep gnawing type pains in the bones, because very commonly prostate cancer can metastasize to the bones. Okay. And then family history of this type of cancer. So, the fact that someone has a family history, their father had lung cancer and they were a lifelong smoker and they had COPD before that, that doesn't really infer an increased risk of this person getting prostate cancer. But if they'd had a family history of prostate cancer, that is an important risk factor. So it's worth asking about things like that. Okay, so now I'm just going to launch the poll again. Okay, just a second. Just pick A or B. Would you offer this patient who's got no symptoms whatsoever a PSA? Just A is yes, B is no. Okay, they're the only options that I want you to select from. Okay, so would you give him the test, yes or no? All right, no other options. They're the only two options here, right? Okay, in terms of the test. There are other things you're going to discuss in the management, but in terms of do you do the test, it's just yes or no, right? Okay, I'll leave that running. While I leave that running, now, in this particular case, the scenario was you're doing a video consultation. Similarly, imagine doing a telephone consultation. You can't reach through the phone or reach through the screen and examine the patient. But let's say you had this same patient with these same things face to face. Would any of you want to examine him, and what would you like to examine? Just put that down into the chat, and then I'll close off the poll in a few seconds as well while I just allow those to come through. Okay. Right, so let's have a look. So people would like to do a rectal examination and do an abdominal examination. Okay. Some people would like to do a urine dipstick. All right. Great. So yeah, the most important thing really, if you had the patient in with you, is to do a digital rectal examination. Now, why is this still important to think about the relevant examinations? Why? Because if you're doing a telephone consult or a video consult, there are some patients where there is a really important examination. And so you then want to convert that telephone or video consultation to a face-to-face consultation, okay? You know, there are some things that, imagine someone wants contraception. You could do the bulk of that over the phone. But if they're, you know, if someone has been stable for many years and their history of their blood pressure has been fine, under the current circumstances, if you didn't want to bring them in, you might give them a prescription and send it to their pharmacy. But if it's someone starting the pill for the first time, I would never write that prescription without bringing them in to check their blood pressure and body mass index, because if it's above a certain level, it might be really unsafe to give them a certain type of contraception, and it might mean we need to change the management. Do you see? So sometimes you need to think about converting the remote consultation into something that needs face-to-face. So it's good that you think about this still. Okay, good. Right, so in terms of management, if we go back to the poll, I just see what people have put. So what's interesting is that 70% of you would offer the test, but nearly 30% wouldn't offer the test. Okay, now in the CSA, knowledge is power. You know, if you know what the guidelines say, you can really confidently deal with management, one, quickly, but secondly, you'll say it confidently with the patient. You won't seem like you're not sure, and you'll be able to move on really quickly. So the right management is that you should offer this patient, even though they're totally asymptomatic. The key reason for that, if I just go back 2 steps, is that it's 51. And what the guidelines say is someone 50 and above, you should offer a PSA test on request. They could be completely asymptomatic, but if they want it, offer it to them. Okay? But before you do, it's important that you counsel them about the benefits and the risks or the downsides, the problems with the PSA. So can anyone think of what are some of the problems of the PSA test? Type that into the chat. And then what are some of the benefits? What are the advantages and disadvantages of PSA as a test? Again, I'll give you a few seconds for that to come through. Okay, so someone said there's a high false positive rate. Okay, and people have said that you could have unnecessary invasive tests. Okay, a lot of false positives. Increase in PSA might be not because of cancer, and you might still end up having a biopsy, which can be painful, or even treatment, which can have permanent problems. So it's got poor specificity and sensitivity. Great. Okay. There's no national screening program for a reason. It doesn't meet the Wilson-Jungner criteria. Okay, because it's not a very accurate test, and because of the downsides. Right. Great. So good. So you're thinking about now. It's incorporating that into your consultation. That before you talk about that, before you offer them the test, say, look, we don't commit too early. Because if you say, we'll definitely do the test, now in their mind, they're going to have it. If you then say these things, you've not really given them the chance to make an informed decision. Do you see? Whereas if you say, okay, look, we can certainly consider that. Before we do, let me just tell you some of the benefits of this test and some of the problems with it. So the main benefits are that, if someone has got prostate cancer, in some cases we can pick it up early, and that can lead to early treatment, which can mean that we have good outcomes. Okay. However, there are some serious downsides to this particular test. A lot of patients that have a negative test still have cancer. 15%. Okay, i.e., we're going to miss it. And so you might feel, okay, I'm fine now, and you've actually got a cancer. But I think the more important thing is the other way, that they're very high false positive. 75% of patients that have a positive or raised PSA, they have a negative biopsy, they don't have cancer. And what that means is, one, they've had that unnecessary biopsy, which is quite painful. But in some cases, they might actually have a treatment like a prostatectomy, and the adverse outcomes of the treatment can be permanent. So things like incontinence and sexual dysfunction, okay? And so we need to bear that in mind, all right? That, in some cases, we might miss things, but in a lot of cases, you might actually have treatment or have additional tests which can be painful, which can be risky, which can lead to infection or long-term consequences, even though you didn't actually have cancer. And even those that test positive, a lot of cases, the cancer would have been a slow-growing one and wouldn't have actually caused any significant problem in terms of clinical harm, okay? Because what we can't test is this a fast-growing or slow-growing tumor? We can just test that it's there, okay? So in terms of management, this is the current guidelines. Anyone over 50 that requests it, even if they're totally asymptomatic, the guidelines say we should offer it to them. Just because of the fact that they might be worried. Like this patient was worried, they had no symptoms, you should still offer it to me. That's the right gut management, okay? When to consider testing, in terms of which symptoms would make you worry about it, if they've got those lower urinary tract symptoms, the erectile dysfunction, or the red flags that make you think they might have cancer or metastases from the cancer, like bone pain, like new onset low back pain, things like that, you shouldn't offer it to asymptomatic men if they're under 50. Whereas 50 plus, you should. And this patient, again, was 51, very close to the border, okay? And then why is it that we wanted to examine? Because if you do examine and you find on your digital rectal examination there's a hard nodular prostate, that suggests that it actually is cancer, then that warrants not just doing some tests, it warrants doing a 2-week work referral for suspected cancer, okay? So that's the current guidelines for management, okay? Again, this is one modified, I've adapted it from one of 100 cases in our CSA 100 case crammer, okay, which I'll talk to you about in a second. But in terms of management, one other thing is in terms of advising this patient, that if they're going to have the test, we need to ask about things like if they've recently had an infection, because if they've recently had a urine infection, PSA can remain raised for many months, but generally we recommend not testing for at least 4 to 6 weeks. That wait till that period, otherwise it's going to be falsely high. That if they'd had a biopsy in the last 6 weeks, there's no point in doing it, it's going to be high. If they exercise vigorously in the last 48 hours or ejaculate in the last 48 hours before the test, it will be inaccurate. So for example, imagine this person, they say that they do circuits. They should avoid their circuit for the 2 days before, because you're doing a high intensity circuit that could affect your PSA. Or imagine now I'm doing that, and I someone that runs 10K regularly, and they do a 10K the day before the test, that's going to put the test off, okay? And then something else, when they have the test, the specimen must reach the lab within 16 hours, otherwise it won't be accurate, okay? And I just wanted to touch on the interpersonal. So, if you're going to ask someone, not just for this case, any case, you're going to ask about sensitive questions like erectile dysfunction, or any question that they might not be expecting. So like here, before you ask about erectile dysfunction, you want to signpost. So here's an example of how you might do that. Now, I know that you said that you weren't having any problems yourself to do with your prostate, or you weren't worried about anything specific. You just wanted to be tested in case you might have this cancer. Sometimes someone might have problems with their prostate. It might not be cancer, or it could be a cancerous, and it could cause problems in other parts of their body, or it could actually cause problems with function of other things. For example, sometimes it can actually affect someone's ability to have an erection. Have you noticed anything like that? Do you see, they understand why you're asking, and they say, okay, you're asking me about something I'm worried about. I can see now that one, you're a knowledgeable doctor, and two, you were listening to me earlier. Whereas if you just ask it out of the blue, they might think, why are you asking that? Did you listen to what I said? I came here about asking for a blood test. I didn't ask about that. Do you see? Similarly, imagine now someone comes in with low back pain and you're trying to screen for cauda equina. We all understand as doctors why we want to ask about bowel and bladder symptoms. But imagine you ask someone out of the blue, have you had any problems with your bowels or your bladder? They might think, Doc, I'm here about my back. Why are you asking about peeing? Why are you asking about my bowels? I didn't come about that. Are you listening to me? Whereas if you said, I know you said that you've been having this back pain. Now, sometimes some very serious causes of back pain can actually start affecting other parts of the body. And it's important we rule those out. For example, in some cases, it can affect your control of your bowels and your ability to pass water. Have you noticed any change there? Do you see, now they see why you're asking that before you ask that, and they see that it's a really important question, okay? We need to give that clear explanation of the benefits and limitations, and then a clear explanation of that PSA is a screening test. That, look, this test might tell us that you may have cancer, and we might need to do a more detailed test that will tell us if it's there or not. It can't say for definite if someone's got it or not. Do you see? It's not a diagnostic test. It's a screening test. A couple of people have just commented that they wanted to join in the clapping. Feel free to join in, okay? With the clapping if you want to. I think it's probably happened by now. I missed the thing because I was paying attention to this, okay? Thank you, everyone, for all your hard work. So I just mentioned our CSA 100 case comment. This case actually was adapted from one of the 100 cases where we go through it in that way. So you can see some of them there. That's also in the discount. All of our online stuff is on the discount, the same code that expires, again, midnight tonight, okay? So that's 100 cases covered in 8 hours of videos. We go through the key things in history, the structure, what not to miss, how to be focused, the red flags, the relevant examination, the current guidelines for management, and then the interpersonal, go through how to explain it clearly. 20 of them are interactive cases. You'll see simulators on screen answering things, okay? Right, so that's the last clinical topic. Now, in the last 10 minutes, I want to talk to you about portfolio GP careers, okay? So I'll start with an introduction to it. We'll look at the advantages and disadvantages. And I'm going to just touch on my portfolio career, just very briefly, okay, in case anyone's interested in it, okay? Yeah, thank you for everyone that clapped. We appreciate it. Okay, welcome back. So what is a portfolio GP? A portfolio GP is a GP with multiple roles. So they might have multiple clinical roles. They might have some non-clinical roles, management, education. They might have some non-medical roles, okay? For example, I'll talk about my non-medical roles, but one of my friends, he's a yoga teacher. That's non-medical. It's not clinical. It's not, it's nothing to do with medicine. Another one of my friends, she's a makeup artist. She's internationally recognized. People fly her out, okay, to do their makeup for weddings or for photo shoots or for movie scenes and things like that, okay? And it could be something you're interested in or passionate about that's nothing to do with medicine. But in most cases, it's a mixture of clinical and non-clinical roles. So that's what a portfolio GP is. So, I have clinical roles, I have non-clinical roles, I have non-medical roles. I'll talk to you about those in a minute. But let's start with some interaction. What are some of the advantages of developing a portfolio career? And it's increasingly popular. I've been teaching about portfolio careers for about 14, 15 years now, okay? But what I've seen is in the last 5 years, a lot more doctors are interested in developing portfolio careers, after they finish their training. So what are some of the advantages first? And then we'll touch on disadvantages. And then I'll tell you a bit more about my portfolio, and then we'll take questions and finish. So someone said variety. Variety is the spice of life, right? Okay, you can pursue different interests. It might prevent burnout, chance to use other skills that you might already have. Someone said multiple revenue streams. Someone else said that do what you love, okay? Someone's mentioned it's a way to housekeep, increase your job satisfaction, allow you to use other passions that might not be to do with medicine, diversity of career interests. It can make it more interesting. Great, so, lots of benefits, absolutely. I think people have got, they say variety is the spice of life, right? I find it really interesting that I do different things on different days of the week and different times of the year, okay? Having a mix of roles. It can be quite challenging. It can be stimulating to do different things, okay? I work slightly more than full-time, all right, between my different roles. But if I worked even full-time in any one of them, I would probably burn out. I would probably be really stressed, okay? But I've seen, like every portfolio GP I know is happy and loves their career. I haven't seen a single portfolio GP that's, really stressed out and, whereas I've seen lots of doctors who are doing full-time clinical work, and the intensity, you see what the intensity is like, that, they are really struggling. And after some time, they often, the stress builds up and they turn to unhealthy ways to deal with it. And, it can have a serious impact on their life, okay? It can allow you to use your existing skills. So, like before I was a GP, I worked in palliative care. And before I did that, actually, I worked in orthopedics for a long time. And so, like, I still do things. I love to do some of the practical stuff. Like, I take my own bloods. Our practice specializes in sexual health, but we do instant tests. So we have like on-site chemicals, and I mix my own chemicals and I do my own tests there. We have like a mini lab on site, if you like. That's really interesting to me. All right. When I do a joint injection, I'm using some of those skills from musculoskeletal orthopedics. I really, really enjoy that. Okay. It's something different. Similarly, I know some of you did ENT before you came into GP, did PEDS before you came into GP, did women's health for a long time before you came into GP. We had come through our program of courses a consultant radiologist that changed to being a GP. She's now a GP, but one day a week she reports films and trains registrars because she had a wealth of experience as a radiologist consultant. It'd be such a shame to waste that, right? Do you see? And so you can use existing skills, but also some of you might want to develop new skills, okay? In terms of money, some roles can be lucrative, okay? I'll talk to you about that on the other side of things as well. And some roles don't require indemnity. So like my medical education work, I don't need additional indemnity for clinical for that, okay? Whereas my different clinical roles, I do need indemnity for. What about the downsides? Any negatives of having a portfolio career? Anyone think of any downsides? Okay, so someone said you've got to be really organized. Sometimes you might mean if you're doing different roles, it might be less time for your family. If you're always working, you could actually end up having a bad work-life balance because you're actually working too much. You might find that you overstretch yourself. You might lose continuity with your patients if you're doing a lot of non-clinical roles and you're not in the same practice all the time. It could actually be stressful keeping up to date with all of these different things, okay? Some people might not like a change in setting. They like to have their room, everything set up. They don't like to be in a different building, doing a different role on a different day and working with a different team, so it actually might be difficult, okay? Someone said, the partner, wife, husband, partner might not be happy if you like it, doing too many hours and things like that, all of those things. Okay, great. So absolutely right. In terms of downsides, you have to keep up to date for all your roles. So like when I have my appraisal, I've got to keep up to date with my clinical stuff, but I also go to medical education conferences. I've got to keep up to date with my medical education stuff. For some of my other roles, I need to make sure I'm keeping up to date with changes with that, like my sexual health role, drug misuse role, things like that. Training can be expensive. If you're trying to develop a new skill and you need to go on a course, a diploma, a certificate, in a lot of cases, you're going to pay for that yourself, right? Money. The majority of things that you're going to do as part of a portfolio career will pay less than just doing additional daytime locum work as a GP. So in most cases, you've got to do it because you love it. Don't do it because you think you're going to make money. There are a few roles which can be very lucrative, but only after you become really experienced and become so good at it that you can be commissioned to run your own service, or you can win a contract or something like that. But generally, most additional roles pay less than just doing locum GP work, daytime, doing clinics in a practice. So bear that in mind. And as people have said, it can be stressful to take on different things, okay? It's about finding the right balance for you, all right? Again, the reason I want to highlight this, every job role has positives and negatives. So I'm going to very briefly tell you about my own portfolio career. And we can split into clinical, non-clinical, and non-medical, just like you could do for any of you, okay? So my clinical, I've been working on and off as a locum in this NHS practice in inner city Birmingham, high levels of deprivation. A lot of patients don't speak English as a first language. Since I qualified as a GP, so since 2007, on and off, I worked there. I've worked and I still, might cover in the summer, for example, the odd session or do some on-call as a prison GP. Okay, I work in community detox. I cover a community alcohol and drug detox unit. So we'll have patients come in who are detoxing off heroin, off cocaine, off alcohol, and then myself or my partner, the other GP who covers the unit, any new admission, they need a full physical. Are they safe for a community detox, or do they need an inpatient hospital detox? This is inpatient, but in the community. Some of them will need to be written up for certain drugs, like reducing dose of diazepam to prevent withdrawal, things like that. I've done medicals for the army. Okay, I opened a few years ago my own private practice, so I'm a partner in that practice, and through that, we now are the resident GPs at Beverly House. This is a secure unit for women with severe mental health. Almost all of them are sectioned. They have a psych team that does their mental health, and then we go in and look after their physical and general practice well-being and preventative care. Okay, so that's my clinical roles. And then another clinical role that I do occasionally, I've had an interest in humanitarian and sort of global health medicine since I was a registrar. Anyone guess which country this is? This was my first outing. I was actually in training like you guys are. I was a registrar, and it was Boxing Day 2004, I think it was. And the tsunami happened. Anyone know what country this is? I happened to have some time off, all right? And then I just felt, look, I'd always said I wanted to do something like this when I qualified. And I thought, I've already got some time off. I really feel I should do something. Otherwise, I won't have an answer if I'm asked, what did you do? So my trainer was really supportive. I said, I've already got some time off. Could I get a bit of extra time off? And I want to go, this is Sri Lanka. Yeah, that's right. It's Batticaloa, Western Sri Lanka, okay? Look how skinny I was then. It was 15 odd years ago. I was very young, okay? So that was Sri Lanka. That was my first outing with Doctors Worldwide. Then there was floods in 2010. Anyone know where this is? You might see it. There's actually a flag there. So this is Pakistan, okay? This is the waiting room for our clinic, okay? This is our team. This guy, he's also a portfolio GP, he's a part-time GP partner, now also does some locums, and then he's the team doctor. He does sports and exercise medicine. He's a team doctor for the England under-18s football team, goes around the world. He was the football doctor for a Premiership League team for 5 years, okay? This doctor, Dr. Shamila, she works in humanitarian medicine more or less full-time, but is also an internationally renowned makeup artist, okay? And then a few years ago, anyone know where this is? This is Lesvos. Remember where there was a big refugee crisis, a majority from Syria, but also some from Afghanistan and a few other countries. This baby is perfectly healthy. He's just swaddled, okay? He's asleep, don't worry, okay? So that was Lesvos. And my most recent one, I'll tell you about in a second. So that's clinical. Then there's non-clinical. My main roles are medical education. As medical director of Umedica, I go up and down the country. So this is teaching final year medical students. This is teaching things like CSA and stage 3. I teach careers. These are all GPs or ST3s about to become qualified GPs. And then I write, okay? I'm also an examiner for Liverpool Medical School for finals, for OSCEs, and for the GMC for PLAB 2. And I put my education and my clinical together last year. I went to Bangladesh, where I was born, and this is the Rohingya camps that you're seeing, one of the largest refugee camps, and nearly 1 million people there now in Teknaf. And here I did something slightly different. I didn't go and see lots of patients, which is what I've done when I've gone previously on missions. I went here as part of an international faculty, and we worked with the UN and Doctors Worldwide, and we developed a program. These are all local doctors, okay? And they're working for NGOs, they're employed, they're being paid, and they're going to be there after we're gone. So we developed like a fellowship program where we train them on how to increase their standards of clinical care, communication, consultation skills, then observe them in clinic and gave one-to-one feedback. And then at the end of this, they get a fellowship, they get a certificate, okay? And that's now been rolled out it's been run several times, and they're looking to now roll that out in other situations and other countries, okay? So that was one of the things I'm most proud of, that I was able to combine the education side and the clinical side, okay? So, and then other non-clinical, author, editor. So I wrote a GP careers guide 10 years ago. I'm currently working on the 2nd edition that should be published later this year. We published these case cards in 2018, the 1st edition. We're on the 6th edition now. I published an Innovate, how to pass the AKT and the CSA, and an MRCGP guide, which is being updated for MPS, okay? And then non-medical, I'm a trustee of a charity. I have an investment portfolio, invest in properties, and then I have invested in various startups. So Draper and Dash do analytics. I've got some investments in Malaysia, and I've just invested actually in Medic Bleep, which is going to replace pagers in hospitals soon, okay? watch out for them. You might see them soon. Okay, and essentially, almost every portfolio GP will have a traditional career option as a base, either a salaried GP or a locum, a lot of them, because it gives flexibility, or a part-time partner. So I have part-time partnership and part-time locum. And then you could add whatever you want: medical education, prison work, working as a police doctor, forensic work, occupational health, medical legal work, assessment work, develop a special interest, work as a clinical assistant doing a hospital role, remote consulting, PCO work, so working for the health board or the CCG doing management, or as a clinical lead for a specific specialty, things like that. Okay, do you see? Anything that you want, basically. Okay, that's all I want to highlight, is that the world is your oyster. GP isn't just one. You're not restricted to one role. You can add what you want. And if you are interested in that, I mentioned this last week, but again, for those of you near the end of your training, our CCT Plus course has a huge session where we go into this in depth. It's on the 4th of July by live stream. We have a whole session on portfolio careers where we'll cover all of these things and how to get involved in them in detail. For example, one of the ways I first got involved in medical education is I started writing questions for an online portal. And we're always recruiting. Some of you, we have doctors who've passed AKT that then write AKT sample questions, original questions. Okay, we don't want any questions that were in the real exam. That would be unprofessional. But original questions mapped to the curriculum to increase our bank. Okay. Similarly, we have people who've passed CSA that write for our CSA. We have people who write every month, and it adds a little supplement to their income. It's something different. We've got doctors who are earlier in training who are writing SJT questions or questions for our SRA, or we're just starting a finals service, so clinical questions for finals level. If any of you are interested and you want to earn some extra money to pay off your exams and your CCT costs, drop me an email, get in touch on Facebook. I'll send you the details. We're always looking for freelance authors to join our team. Okay, we've already got a huge team. So that's a summary of portfolio careers. As I said, just a flavor. Okay, if you're interested in that nearer the time of your finishing, come to the CCT Plus course. We cover it in a lot of depth. Right. Any questions? Ask them in the Q&A. Before I go through the questions, I'm just going to do the summary for those that are leaving. Just a brief reminder that 20% discount will end at midnight tonight. It's lockdown, all lowercase. Okay, you can use it on any of our webinars, online courses, online revision, the online bundle, case cards, any of those things. You can use it more than once. You could use it on the case cards and on some webinars, or the bundle, which has all of it. It will expire at midnight tonight. Okay, so just to remind you. And then before we go, something really important. Do join the GP training support group if you haven't. I will send you a recording and the slides by tomorrow evening. Please register for next week. Next week won't be on Thursday. It's going to be on Wednesday, because I'm on leave from Thursday for a couple of weeks. Okay, so I'm going to run it on Wednesday so that I can get one more in before I go away, because I know it's an important time for you guys, especially because we might have more details about the CSA exam by then. Okay, so it's not going to be on Thursday. It's going to be on Wednesday, the 13th of May, but at the same time, 7:15 to 8:15. So please share with your VTS. And then for those that are leaving, just before I go through the questions, I want to leave you with this. It's from Muhammad Ali, but it's really important. Don't count the days, make the days count. What do I mean by that? I've had a lot of people contact me and say, look, I'm a bit stressed because I don't know when the date's going to be in July. I haven't got the details of this CSA, and there's not much time. Normally the Royal College says allow 3 months to revise for AKT. There's not 3 months now. I wasn't studying before because of the stress of work and having my kids at home. How can I deal with this? First thing I can say to you is you can give yourself certainty by starting revision today. Okay, you've already started because you're here today, so well done. Okay, you've taken the first step, and that gives you certainty that you can do something. That even if you've only got 60 days where you would have liked to have 90 days, make each day count by studying in an efficient way. This is where things like our webinars and our recorded courses can help you. You could, of course, read all of those things and read individual NICE guidelines yourself, but it's going to take you hundreds of hours. We've made it concise because we've done it, and then like the slides I've given here, where we might take a topic and summarize it into just 2 or 3 slides, and the bullet points are concise, so it's easy for you to remember it. Okay, but each day do something, make it efficient, make the days count, and then you can succeed. Prepare and you will succeed. Okay, so give yourself some certainty. Just imagine the exam is on the first weekend of July. Okay, and then if you work towards that, if it's a bit longer, you've got a bit of extra time. Don't imagine it's at the end of July, because then you might fall short. Just make a start and make a plan to finish your revision by the first week of July. And then if you have a bit of extra time, do a few extra mocks, a few extra practice. It's bonus, isn't it? That's how you can give yourself some certainty and then make the days count. Okay, so thank you very much for joining me. I hope you found it helpful. Hope to see you next week on Wednesday evening, not Thursday. Thank you so much. Prepare and you will succeed.